Well, we're pleased to report the first targeted therapy trial in BRCA1 and BRCA2 mutation carriers with breast cancer. And what we've done is we've done a trial of the oral PARP inhibitor olaparib in women with advanced breast cancer on the background of BRCA1, BRCA2 mutations. We've taken two cohorts of women and exposed them to two different doses of the drug olaparib and studied whether or not their tumours have responded to the drug. What we've shown is that in a heavily pretreated population of patients who've had a median of 3 prior chemotherapy regimens and at least one for advanced disease, that we're showing 40%, 41% of patients with objective confirmed tumour response in the higher dose cohort.
That's quite remarkable.
I think it is in women who've seen a lot of chemotherapy before and for a single agent strategy. These are women with mutations, and a lot have BRCA1 mutations. So over 50% of women in the study have triple negative breast cancer, but 30 to 40% of women have ER positive breast cancer, and usually that's the BRCA2 mutation carrier population. We've also shown that olaparib was very well tolerated in this population, because we would predict from the science that underpins this work that the effect of this drug would be selective on the tumour cells which are devoid of their BRCA1 and BRCA2 function, whereas the normal tissues retaining a single normal copy of the gene are able to cope with inhibition of PARP. And indeed we see little in the way of normal tissue toxicity. Well, we still have patients on study responding to drugs, so the median is a difficult term to give, but we're seeing 4.8 months as a median duration of response at present in the higher dose arm, and very similar in the lower dose arm, although a smaller proportion of patients appeared to respond to the lower dose of the drug. Indeed, I mean, I think there are two different potential approaches to this class of drugs. One is targeting defective homologous recombination, and I think what we're showing in this proof of concept study is that approach as a single agent in cancers that have homologous recombination deficiency appears to work. The other approach is to use inhibition of PARP as a chemosensitization strategy, and perhaps there's an overlap there of chemosensitization occurring in cancers with some homologous recombination defect. Those trials are ongoing, both with olaparib in combination with other agents, DNA damaging agents, non-DNA damaging agents, but also with other PARP inhibitors that are being combined. It is not inconceivable. I think we have to remember that at this stage these are data in an advanced disease context. We need to know whether this is a drug where the inhibition of DNA repair, perhaps in a long-term context, is a safe approach. That said, for women at high risk of developing breast and ovarian cancer because of underlying BRCA1 and 2 mutations, this is inevitably a very important question for them. Currently, they have surgical risk reduction strategies which are effective, but it is an open question as to whether an alternative approach may be helpful. More safety data required.